5, 4, 3, 2, 1, live.
I think I'll take the lead. Good evening, everyone. First of all, I would like to thank the organizers for starting this academic feast under the aegis of Chhattisgarh Chess Society. This is a very well start and beginning, a small beginning, and hopefully we will all continue to do it very frequently so that we are interconnected and we keep on learning from each other. I would like to welcome the eminent speakers today. First one is Dr. Sonali Trivedi. She is a senior consultant and pulmonologist at JRN Hospital and Research Center. And she also has got DNB students under her. And I would like to introduce another speaker who is a young and dashing Dr. Devi. I keep on interacting with her as well, and I keep on taking academic inputs from her whenever I need to go for a seminar or something like that. She is working as an assistant professor. Am I right, Dr. Devi? As an assistant professor at our own medical college, Pandit Jawaharlal Nehru Memorial Medical College. Today, both of the speakers are talking on airway diseases, COPD and bronchial asthma. So without taking much time, I think I will like to hand over the mic to Dr. Sonali Trivedi to start the session. Dr. Sonali Trivedi, you are most welcome.
Good evening. Thank you, Dr. Pillai. Good evening, respected seniors, friends, and dear colleagues. I am thankful to the CG Chess Society and Lupin for giving me the opportunity to talk on this forum. You know, the life expectancy has increased partly due to the significant improvement in the treatment of communicable diseases. This has resulted in epidemiological transition from early mortality caused by transmissible diseases towards a higher prevalence of non-communicable diseases causing deaths at an older age. Non-communicable chronic conditions are characterized by their slow cumulative progression, making them clinically apparent at a later stage of life. Am I audible, I think? Am I audible?
Yes, ma'am.
Yes, okay. Ma'am, you're audible.
Thank you. So COPD is a chronic model of complex disease by start in early life, progress very slowly over a time, and often is diagnosed when the patient reaches their 6th or 7th decade. As age advances, the individuals are likely to have more than one co-occurring conditions, a phenomenon known as multimorbidity. Since comorbidities are frequent in COPD patients and significantly impact on patients' quality of life, survival, and exacerbations, hence needs to be discussed. And we must be prepared to manage individuals with concomitant chronic diseases. My slides are not visible. Is it visible to you?
The slides is not visible, ma'am. Just can you on the slide minimize this browser?
Okay.
The minimize, yeah, and just open the presentation, ma'am.
No, I'm not getting.
Just make sense. Yes, perfect. And make it full screen, ma'am.
Okay. It is full, I think.
Ma'am, there is.
Is it okay now?
No, ma'am. Just click this thing. Yes, slideshow. Perfect, ma'am. Continue.
Okay. But nothing is coming in my slide.
Click next, ma'am.
Okay. So the most common in clinically, COPD per se is a third leading cause of death worldwide. Yet, up to 2/3 of the individuals suffering from COPD die of non-pulmonary causes, mainly the cardiovascular diseases and lung cancer. The most common and clinically important comorbidities in COPD patients are ischemic heart disease, congestive heart failure, hypertension, anxiety and depression, musculoskeletal diseases like osteoporosis, GERD, CRF, pulmonary fibrosis, and of course, lung cancer. So there is some problem in my slides. I am unable to see this thing.
If you are something is on your slides, just minimize the video.
I'm not getting.
Ma'am, we can see you very clear. We can hear you
Okay.
as well as we
Okay.
can see your slide also.
Okay, but I am unable to see this thing. I mean, the whole slide is not visible to me.
Just minimize, ma'am, or make it full screen. Make it zoom is a full screen, ma'am. Just double click on the zoom.
Bad to see. Sorry, unable to do it. Yeah, now it is okay. So there is an interplay between the symptoms, COPD comorbidities and their symptoms. There are these varied ways in which the COPD and the comorbidity themselves interact together are displayed here very well. You can see. You can notice the dyspnea and cough are central features of many comorbidities, thus clarifying the exact cause of these symptoms are more likely, which combination of comorbidities are involved and to what extent in such patient can be challenging. What is the impact of comorbidities on COPD? Most of the studies have centered primarily on the identification of the most frequently observed comorbidities and their prevalence in COPD patients compared to the general population without these diseases and their impact on patients centered outcomes such as mortality, quality of life, response to pulmonary rehab, and hospitalization. It is observed that not all comorbid diseases present in patients with COPD are associated with same prognostic implication. The combination of multiple comorbid diseases along with respiratory impairment also resulted in higher risk of death. For example, a subject with gold stage 3 or 4 COPD and all three comorbid diseases had a 24 higher risk of death than the subject with normal lung function and no comorbid disease. Next. Does comorbidity increases exacerbation? Yes. This is very well depicted in this picture. The proximity to the black center of the circle represents a stronger positive association with more than 2 exacerbations per year. These patients have a higher risk of having frequent exacerbation compared to those who did not have such comorbid conditions. So several comorbidities which are associated with increased exacerbations include GERD, anxiety, depression, pulmonary embolism, pulmonary hypertension, and cardiovascular disease. Comorbidities are important determinants of future risk in COPD patients, and they should be considered in the assessment of future risk. The presence of cardiovascular disease, arterial hypertension, diabetes mellitus in the patients who are hospitalized for acute exacerbation of COPD is associated with higher risk of exacerbation and hospitalization for COPD in following years. Does comorbidity these diseases are important because they can screen for and by the physicians or healthcare providers with the tools which are common to most practices such as ECG, 2D echo, CT scan, BMD, mammography, and can help to detect the most of the these prevalent diseases with COPD. Impact of each comorbidity on the mortality risk of patient with COPD is demonstrated. For example, the patient with COPD with the hazard risk of all-cause mortality associated with concurrent pulmonary hypertension is 1.27 to 1.4. For example, in patient with pulmonary hypertension, the hazard risk of all-cause mortality associated with concurrent COPD is about 1.59. This is very well predicted in this picture. Does comorbidity increases the mortality? Yes. In patients with severe COPD, the respiratory failure is the most common cause of death. But however, in earlier stages of COPD, the cardiovascular and lung cancers are most common. The comorbidities which are associated with significantly increased mortality includes the heart failure, ischemic heart disease, and metabolic disorders. Number of comorbidities is an important independent predictor of all cause comorbidities. This figure very well depicts the mortality hazard ratio of major comorbid COPDs. In addition to the well-known causes of like IHD, pulmonary hypertension, and GERD, etc., perhaps less prevalent but important because of its close association to increase the mortality is a diagnosis of anxiety. This frequently unrecognized disease need to be considered because its detection and treatment can help these patients profoundly. Now let us discuss what is the impact of comorbidities on osteoporosis. There is some, I need to discuss the inflammation first. There are several origins of systemic inflammation in COPD. In spillover hypothesis, the inflammation begins in the lungs following the exposure to tobacco smoke or other oxidants worsens. Also, there is an increased airflow obstruction. It spreads through the systemic circulation by inflammatory cells and mediators, potentially causing the extrapulmonary manifestation. You can see the inflammation. Chronic inflammation is the main string of the pathophysiology of COPD. So also in other disorders also like cardiac diseases and osteoporosis and musculoskeletal disorders. As it is well known that COPD and coronary artery disease is highly prevalent and both share the common risk factors such as exposure to cigarette smoke, old age, sedentarism. The most attractive link between these two diseases is the presence of low-grade systemic inflammation in both. Hence, it is recommended that patients should be screened. Patients with COPD should be screened for the presence of concomitant atherosclerosis, and just as importantly, the patient evaluated for the atherosclerotic diseases should be investigated for concomitant presence of airflow limitation also. Now the mechanism of osteoporosis. How osteoporosis is related to COPD. Again, the systemic inflammation of COPD and decreased lung function themselves are implicated in the development of osteoporosis. It has been proposed that several inflammatory mediators which are increased in COPD, such as MMP9, TNF-alpha, IL-6, they interact with the OPG, rank and RANKL system, which controls the osteoclast differentiation, maturation, and activation. And other bone remodeling pathways may also be involved. The presence of osteoporosis in patients with COPD has a negative prognostic bearing in that the thoracic vertebral compression fractures due to osteoporosis are associated with pain, increased dyspnea, worsening kyphosis, decrease in vital capacity, and reduced exercise tolerance. In fact, for every vertebral fracture, the FVC is reduced by 9%. How it is related with the metabolic diseases? The COPD increases the risk of developing diabetes and hypertension. In patients with COPD, the prevalence ranges between 10 to 25% of diabetes. The exact mechanism for increased prevalence remains still unclear. However, the inflammatory markers are raised both in obesity and COPD, as you all know, which is correlated with increased insulin resistance. Thus, the systemic inflammation is likely to have a role. Decreased physical activity and frequent use of steroids may likely to contribute in metabolic syndromes association. The diabetes is also known to increase the mortality in patients with concurrent COPD. The hazard risk is around 1.5 to 1.7, which I already mentioned, I think. Now let us discuss the mechanism of involved in COPD and metabolic syndrome. The COPD increases the risk of developing, I think am I repeating this thing? Yes. Sorry. So the COPD, as you all know, the oxidative stress and systemic inflammation are the mainstream of COPD pathophysiology. As well, it is also shared with the coronary artery disease. So combination of increased risk factors in patients with COPD, chronic systemic inflammation accelerates the atherosclerosis. 70% prevalence rate of cardiovascular diseases has been observed in COPD patients. Cigarette smoking, as I already mentioned, it is a common risk factor for both the diseases. Systemic inflammation, as already told, is in mild to moderate degree, may contribute to increase the cardiovascular risk in patients with COPD. Actually, both systemic inflammation and endothelial dysfunction are the key pathogenic mechanism for atherosclerosis. So, to summarize, the co-occurring diseases like heart failure, ischemic heart disease, pulmonary hypertension, fibrosis, metabolic syndromes, osteoporosis, GARD, are significantly prevalent in COPD patients ranging from 2 to up to 70%, and share the common risk factors like smoking, age, sedentarism, and may present with the similar symptoms like cough and dyspnea, and have an important impact on quality of life, exacerbation, survival of these patients. So, the take-home message: comprehensive approach to management of COPD risk factors and careful assessment and treatment of coexisting illness may dramatically improve the mortality and patient-related outcome. The extrapulmonary comorbidities are common and significant in COPD patients, often contribute to the symptoms, exacerbation, and hospitalization, and they have significant impact on the health status. So justify the need for comprehensive and integrating approach. So it is crucial that COPD, as a COPD clinician, should focus their attention not only to the management of COPD itself, but also to the investigate and manage the COPD comorbidities. Thank you. Sorry for disturbance.
Thank you so much, Dr. Sonali. I think that straight away we will go to another speaker, and I would like that we will all take the question answer session at the end of both the talks. And I hope Dr. Panda has also joined us. Dr. Panda, are you there? Hello, am I audible?
Yes, you are.
Dr. Panda is still not joined us, it seems. Okay, now I would like to welcome the other speaker, Dr. Devi. Dr. Devi, please continue with the second talk.
Yeah. Thank you, sir. I am Dr. Devi Jyoti Das. I am assistant professor in Bhimrao Ambedkar Medical College and Hospital, Raipur. Ma'am, yeah, okay. I will share my screen now.
Panda is there. Panda? No, Panda is not here. No? Is it Dr. Panda?
Yes, sir, he is.
Is there? Dr.
Yes.
Devi, one moment. Sorry. Panda,
Yeah,
can
sure.
you hear me? Ravindra? I don't know what he has kept his microphone muted or what?
Yes, sir.
Ravindra, are you there?
Yes, I'm there.
Ravindra, you're most welcome. I would like to welcome our dynamic secretary of our Chhattisgarh Chess Society, Dr. Panda. in the capacity of a president of the Chhattisgarh Chess Society. Dr.
Thank
Ravindra
you.
Pandya will, first of all, I would like to thank him despite his busy schedule and his responsibility for the COVID. He has taken time to join us, and he will be taking care of the question answer sessions and the vote of thanks. Okay, Ravi?
Okay.
Okay. Thank you so much. Now, Dr. Devi, please go ahead with the talk. Yeah.
Yeah. Thank you, sir. I want to thank Lupin and the CG Chess Society for giving me this opportunity. And today I will be talking about revisiting the role of salmeterol fluticasone combination in COPD. Am I audible to all?
Yes, yes. Go ahead, please.
So, as very nicely already explained by ma'am, there are many comorbidities which are associated with COPD. Cardiovascular diseases are about 70% prevalent in patients of COPD. Osteoporosis is very much prevalent in patients, almost up to 70% in some studies. Also, there are many metabolic syndrome, psychiatric diseases, other respiratory diseases like concomitant asthma, obstructive sleep apnea, GI diseases, etc. So COPD can be managed well only if we treat the whole disease and the whole patient and not just their respiratory aspect. So COPD, as it is a systemic disease and a multi-system disease, we have to treat COPD as a whole disease. So coming to the individual drugs of our combination, salmeterol has some distinct properties, like it is highly beta-2 selective molecule. Here this line represents equal affinity to beta-1 and beta-2 receptors. So compounds occurring to the right and below are beta-2 selective. As we can see, salmeterol can be seen to be highly beta-2 selective. Another distinct property is its long duration of action, and it is mainly due to its lipophilic property to remain in the airway tissue as a depot in close vicinity to the beta-2 receptors. The long duration of action has also been suggested to depend on an anchored binding with the beta-2 receptor. Salmeterol has lower impact on plasma potassium concentrations and lower tremor score even at highest doses as compared to other long-acting beta-2 agonist. So coming to salmeterol fluticasone combination. So salmeterol, as we have already discussed, has a greater affinity to beta-2 receptors, which is non-competitive and having slow dissociation. Fluticasone is a very potent ICS. It has high lipophilicity and a longer duration of action. So this combination, shortly called as SFC, salmeterol fluticasone combination, has a highly selective bronchodilation without cardiac acceleration with a longer duration of action. Now we will be discussing important studies regarding this. So this is a study of survival in COPD patients after regular use in fluticasone, propionate and salmeterol in general practice in peripheral health centers. So here, as we can see, that salmeterol has the highest relative risk of death, fluticasone has a lesser risk, and SFC combination has the least risk. So regular use of fluticasone propionate alone or in combination with salmeterol is associated with increased survival of COPD patients managed in primary care. This study was done in primary care population in general practice. Coming to the effects of inhaled corticosteroids on bone density and metabolism. So here we can see there are two graphs, and the blank white one shows the action of beclomethasone, and the diagonally striped one shows the action of fluticasone. So here in this graph, we can see that there is significant decrease in osteocalcin after the use of beclomethasone, but non-significant decrease in after 6 weeks of use of fluticasone. Similarly, here there is significant decrease in the levels of PICP, that is procollagen type 1 carboxy terminal propeptide, and both osteocalcin and PICP are indices of bone formation, but the PICP level are not decreased with fluticasone. Thus, fluticasone propionate did not influence bone metabolism in contrast with beclomethasone. Now, these are a similar study of osteoporosis in patients with COPD, and the results are from the TORCH study. So, towards a revolution in COPD health, that is, the TORCH study is a landmark study in COPD where they investigated the long-term effects for 3 years of therapy with fluticasone propionate alone, salmeterol fluticasone combination, and placebo on various actions or various aspects of COPD. So this study shows the results from the TORCH study, and here they have evaluated the role of fluticasone, salmeterol, and the combination on bone mineral density and bone fractures. So the results show that no significant difference were observed when comparing changes in bone mineral density over time between any of the active treatment groups. And the incidence of fractures was low and was similar for all treatment groups. Thus, they concluded that osteoporosis is highly prevalent in patients with COPD. And in this study, no significant effect on the bone mineral density was detected for fluticasone therapy compared with the placebo. Now coming to the cardiovascular safety of salmeterol in COPD. Here on the left side, we can see a 24-hour heart rate measured by the Holter monitoring. So here we can see the heart rate after placebo, and here we can see after salmeterol. So we can see that there is no significant change. And on the right side, they have measured the QTC interval after placebo and salmeterol. So there was no evidence of an effect on the mean or maximum 24-hour heart rates, no significant sympathetic stimulation of the heart in COPD, and no increase in cardiovascular adverse effects risk in COPD patients compared with placebo. So salmeterol was found to be safe cardiovascularly. This is another result from the same TORCH study, which shows that here we can see that this continuous line is the SFC combination, and they have seen this for more than 3 years. So the probability of patients having an ischemic cardiovascular adverse effect by 3 years was lowest for salmeterol fluticasone combination at 11.3%. So it was concluded that SFC did not increase the risk of cardiovascular events in patients with moderate to severe COPD, thus showing it is not harmful for cardiovascular health. Here is a very interesting meta-analysis published in PLOS One in 2015, which analyzed 24 randomized double-blind parallel group placebo-controlled trials, and it showed that inhaled long-acting beta-2 agonists do not increase fatal cardiovascular adverse events in COPD. In fact, they decreased the fatal cardiovascular adverse events, and among the different type of long-acting beta-2 agonist, only salmeterol had a significant effect. Now coming to effect of fluticasone and salmeterol combination on arterial stiffness in patients with COPD. So arterial stiffness is measured by aortic pulse wave velocity. So in this study, which was a multi-center randomized double-blind placebo-controlled study, they showed that the salmeterol fluticasone combination, that is the SFC, did not reduce arterial pulse wave velocity in all COPD patients, but it had effects in those who had already elevated arterial stiffness. So we can say that in patients who already have arterial stiffness, who already have increased aortic pulse wave velocity, they will be benefited by this SFC combination. So to conclude my talk, COPD is a complex disease associated with low-grade chronic systemic inflammation. In clinical practice, these systemic effects translate into the comorbidities, which have a significant impact on patients' well-being and prognosis. Bronchodilators are the mainstay of COPD treatment and can be combined with inhaled corticosteroids for more efficacy and fewer side effects. Cardiovascular safety of salmeterol in COPD patients has been well established. Salmeterol has lower impact on plasma potassium concentrations and a lower tremor score. Fluticasone has no significant impact on bone mineral density and does not increase the osteoporosis. Thus, salmeterol-fluticasone combination can be used safely to manage symptoms, improve the lung functions, potentially decrease exacerbations, and improve the quality of life in patients with COPD. Thank you.
Thank you so much, Dr. Devi. Before I hand over the mic to our Honorable Secretary, Dr. Ravindra, I would like to thank everyone, all the colleagues, all the organizers for organizing this fantastic meeting. And I would like to take permission to leave. From here on, now Dr. Panda will be taking over the session. Thank you so much.
Sir, very good evening, sir.
Good evening.
Good evening.
Yeah.
Good evening.
Yeah, sir, how are you, sir? Shomok speaking. How are you, sir?
I'm fine. Dr. Panda.
Fine, sir. Sir, you can continue, sir.
No, just continue. Hello.
Yeah, Ravindra, we can listen to you. You go
Hello.
ahead. Yeah, we can listen, Ravindra. Go ahead. Please go ahead. I think there is some audio issue with Dr. Ravin. Ravin, can you hear me?
Okay. Yeah, thank you, Jyoti, for a very excellent topic. Anybody having, I don't think so, as we are all pulmonologists. Yeah, I can. Hello.
Ravin, your video is off, switched off, I suppose. We can hear your audio is okay, but you're not visible.
No, his video is on, but some problem with the network, I think.
Okay.
Because it is not.
But we are audible. Ravin, you go ahead.
Yeah, okay. Jyoti, thank you for a very excellent talk. And I don't think so after giving such a beautiful talk, anybody would be having this type of any doubts. But if they also, then there is always Jyoti is there to clear the doubts anybody having. Hello. Does anybody having any doubts?
I don't think so, broadly.
Yeah.
Any questions are there? Anybody has got any questions?
Yeah. I think now Dr. Pillai sir to take over and start the next session.
Acha, I would like to ask Ravindra, is there any protocol for the live sessions? Like, can we do? And I would like to ask the organizers also. We are missing.
Yes, sir. Yes, sir.
We restarted the live sessions. Can we restart it? Is there any directives like small meetings? Can they be organized?
No. Small get together is allowed basically.
Yes.
Okay. A large get together is not allowed.
No.
People of 10 to 15 can definitely have a live and
thank you
live
so much.
session.
Because I would like to request the organizers that next time if they do it, they can do it in a physical form. Even if you invite 30 to 40 people, hardly 10, 15 people only turn up. So at least again we can restart, the things.
Sir, definitely, sir. Actually, this time due to COVID, that's why we have to do this kind of webinars. Sir. Otherwise, we are basically believe in the physical meetings. Definitely. So next time I will keep it in mind. So next time when the update will be there, we will have a definitely physical update, sir.
Thank you so much. So I think we should conclude, Naravind.
Yeah, definitely.
Okay, I will hand over the mic to the organizer. You can put a word or a couple of sentences and conclude the meeting.
Yeah, sir. Very good evening, sir. On behalf of Lupin, this is Shomok, sir, regional head of the Lupin Limited. So I must congratulate to Dr. Pillai, Dr. Panda, sir, obviously Jyoti ma'am, and Sonali ma'am for their beautiful talks on the particular COPD and other parts. So it will be a very interesting as well as elaborative session from both of you. So on behalf of Lupin, I must thanks to all of you, sir. So and obviously, as Dr. Pillai has
Thank you.
mentioned, next time we will definitely have a physical meeting. So that will be much more beneficial, I must say, and definitely we will meet with each other. That is the most important, sir.
It
Okay.
is a
Thank you.
long time since we have met, in person. Like,
Definitely, sir.
yeah.
Right. Thank you to all
Thank
of
you
you,
so much.
ma'am.
Okay,
All of
Thank
you,
okay,
you.
sir.
bye guys.
Thank
Good night.
you.
Good.
Thank
Thank
you,
you so
Dr.
much.
Panda. Thank you, Dr.
Thank you.
Tillai. Thank you,
Thank you
Jyoti.
so much. Thank you guys. Thank you. Bye bye.
Thank you. Bye.